This talk is going to be a little different than the prior two, and I guess now that I've admitted to all of you this morning that I don't use the GRACE risk score, I feel there's a weight off my shoulders, but it doesn't mean I don't do risk stratification. This is really going to play into a little bit of what we're going to do in a couple of the workshops and think about multivascular disease or polyvascular disease. All right, so first a question. So do you think that diagnosing peripheral artery disease, and by that I mean lower extremity artery disease, do you think it's informative in your patients who present with an acute coronary syndrome? Yes or no? Okay, yes, good. All right, well, let's go on then. There's no right answer. I was just going to ask your opinion there. So I want to begin with the observation from registries, from real-world data. This is the REACH registry, about 20,000 patients. That the number of symptomatic vascular territories is an important risk stratifier. Now, I learned as a cardiology fellow from Peter Libby, who told me that aterosclerosis is a systemic process. If you have it in one territory, it's everywhere. So in some ways, this is counterintuitive, but the fact that people may have more severe disease or symptomatic disease actually is a potent marker, even after you adjust for other risk factors. And here, whether you're looking at MI, stroke, cardiovascular death, or a composite, there's about a 60% excess in those who manifest symptoms in multiple territories. Now, this is more of a trialist game on this slide, and it really goes to show you how consistent this finding is. On the left side of the slide is the Euclid trial. That's a peripheral artery disease trial. And if you add concomitant coronary disease, there's a 50% excess in risk. And in the right, there's Pegasus TIMI 54. That's a coronary trial. And if you add PAD, you get the exact same thing. So this is reproducible in registries, in randomized trials, whether or not you're looking at a peripheral artery disease patient or a coronary patient. And this explains some of what we see in other studies. So, for example, in the Fourier trial, we noted that patients who had peripheral artery disease in the lower extremities were higher risk than patients who had actually had a prior MI or stroke, about an 80% excess in risk. But the truth is more complicated. And actually, when you stratify that group with peripheral artery disease, it's those that have polyvascular disease that are the highest risk. And that red bar really, that red line really shows you it's a very malignant phenotype, and it's not just systemic atherosclerosis, but it's the severity of atherosclerosis and the fact that they're symptomatic in multiple beds. And one of the questions that always comes up when you look at those type of data are maybe those multiple symptomatic territories are just aliasing for other risk factors. They're just sicker patients, right? And we adjust the analyses and so on, but maybe it's really just identifying patients with more comorbidities. And this question came up in the Improve It trial. I actually worked on this paper with Dr. Bromwald, and we thought, well, maybe it's just a surrogate for things like diabetes. But when you stratify, you see that the risks are not the same. You can see that both polyvascular disease and diabetes in the yellow and blue curve in your ACS patients are informative in terms of risk. But if you combine the two, it's actually additive. So knowing whether your ACS patient has diabetes and knowing whether your patient with ACS has lower extremity peripheral artery disease, these are simple, easy risk stratifiers. And the overlap of the two, which is quite common, you can see results in an event rate of about 50% at 7 years, very high risk phenotype. So it matters not only in identifying risk, but then by nature of that risk, those patients, even if they have the same relative risk reduction with therapies, derive a greater absolute benefit. And so you can see here with ezetimibe in the Improve It trial, modest LDL reducing therapy, that if you take patients with peripheral vascular disease or with or without diabetes, you have a more favorable number needed to treat. And if you take that group that has both, you get a number needed to treat of just 11. So greater absolute benefit, a simple way of risk stratifying and identifying a group that derives greater benefit. Well, the same holds true for the PCSK9 inhibitors, a more potent way of reducing LDL cholesterol. But here in data from the Odyssey trial, you can see in patients with 1, 2, and 3 beds, a clear gradient of risk. And then you can see the absolute risk reductions in the upper left-hand corner that range from 1.4% with single vessel or single vascular territory to 13 with those that had triple vascular territory. So I think that this is a very useful and approachable way of risk stratifying patients. It does matter if you know whether they have multivessel or multi-system disease. But it's not just a question of risk. It's a question of knowing what risk your patient faces and actually tailoring therapy to what they're concerned about. Patients who have carotid disease, patients who have extracranial cerebrovascular disease, patients who've had strokes, they're at highest risk of stroke, and this is one of their most feared outcomes. And in fact, we see that LDL lowering is very effective at reducing the risk of stroke. So knowing that they have carotid disease and they're worried about this outcome helps to inform how you have that discussion around risk. And similarly, for the patient with lower extremity artery disease, those patients, they come to you often because their legs hurt. They're worried about acute limb events, particularly amputation. And again, LDL lowering is exquisitely effective at reducing risk here, 57% relative risk reduction. And when you look at the components, these are not, these are not interventions for claudication that we're talking about. We're talking about major amputations and acute limb ischemia, the sort of heart attack equivalent of the legs. So understanding what territories are involved, depending on what bed your patient has, helps you frame the discussion around your preventive therapies. And in fact, that relationship between LDL reduction and limb outcomes is linear. You can see by achieved LDL at 1 month in the Fourier trial here on the horizontal axis, as you move left, there's a continuous benefit for limb outcomes that extends to an LDL cholesterol below 10 milligrams per deciliter. And that, of course, comes, we have to always think about safety, but with no important side effects, at least during the observation of the trial. So in summary, polyvascular disease or multivascular disease is a potent independent predictor of MACE. That extends beyond acute coronary syndrome and beyond diabetes mellitus, even in your ACS patient. In addition, patients with polyvascular disease have a heightened risk of territory-specific events. Carotid and stroke patients, they're worried about stroke. They have high rates, lower extremity artery disease, major adverse limb events. So diagnosing polyvascular disease is important, even in patients you already think or know are high risk, your ACS patients, and identifying a group that has a malignant atherothrombotic phenotype that warrants early and intensive risk factor modification. Thank you.